Good day, dear physicians. This is Dr. Farah, and welcome to my internal medicine platform on YouTube by the name of 3MD. The name of the playlist is Exam Sensitive Teachings. Today is lecture number 5E. The topic that I have chose is basically a drug which is known as thrombopoietin receptor agonist. Is that when is this drug used? What are the main indications as of rather strongly considering this drug in a patient who is diagnosed with immune thrombocytopenia? So what are the names for immune thrombocytopenia? It's also known as idiopathic thrombocytopenic purpura and immune thrombocytopenic purpura. I hope you guys know that it's an acquired thrombocytopenia which is caused by autoantibodies against platelet antigens. Okay, and it can be secondary, and the main secondary causes in USA can be SLE, and it can be HIV, which is very common, and hepatitis C. Now, before I reach this concept, I would like all of you to understand and observe this clinical algorithm, which defines the correct treatment protocol in a patient who is confirmed with ITP. So basically, up to date advises us to check the platelet count after you diagnose the patient with ITP. You do not immediately jump to glucocorticoids. Firstly, you have to look at the platelet count. If less than 30,000, or remember the word is or, it's not and, or bleeding, then what do? Then you start glucocorticoid therapy, and at the same time it depends upon the patient's condition. If the patient is prominently bleeding, like there is a severe GI bleed, an intracranial bleed, or on physical examination there's a demarcation like mucosal purpura which indicates bleeding, then you have to give IVIG. Remember, this is exam sensitive question. Firstly, let me just tell you a very important point about IVIG, that it's also known as a rescue therapy. Why? Because it abruptly raises the platelet counts. It takes no more than 1 to 2 days. 1 to 2 days. Okay, this is exam sensitive question. IVIG is a rescue therapy. Now what next? Let me tell you something about glucocorticoids. The most common treatment regimen which is used among the glucocorticoids are the high dose dexamethasone. You do not need to know the dose, but it's 40 mg and it's given per orally, okay, and it's not given chronically. This is very important. It's given for 4 days, and is tapper given? No tapper. This can be a potential exam sensitive question. No tapper. And the other drug that is considered is oral prednisone, and it's given 1 mg per kg per day, and this is given for only 1 to 2 weeks. And this oral prednisone is followed by tapper. So I hope you will remember these concepts. These are quite much important. Okay, so now if the patient has severe bleeding, then in that case you can consider intravenous methylprednisone. Okay, in severe bleeding you can give intravenous methylprednisone, and the second option in severe bleeding, it's not oral prednisone, it's high dose dexamethasone. Okay, now after that you have to check the response. I hope you know what a better response is and what's a good response, means a complete response. So there's a response. This can be a better response as per up to date, and then there's a complete response. So what's a better response? When the platelet count rises above 30,000 per microliter, or at least there's a doubling of the baseline platelet count. Like if it's 10,000, then a doubling has occurred, and now the new platelet count is 20,000. So there is a doubling of the baseline platelet count. And what's a complete response? It's defined by uptodate.com as when the platelet count reaches above 100,000 per microliter. These concepts are quite much important, both for your exam and your wards. Now, after glucocorticoids and IVIG, the patient did not achieve a better response, neither a complete response. Again, we look at the platelet count. Now, the patient has the decline even worse. Platelet counts have gone down further, means the patient is clinically deteriorating. Now, what to do about? Again, when we check the platelet count, if less than 20,000 or the patient is bleeding, then this is the time we consider a second-line therapy. The first two drugs are commonly given in the second-line therapy. The first two procedures are considered in second-line therapy. One is the splenectomy and the other is the medication Rituximab. Now, in first-line therapy, when do you start first line? When the platelet count is less than 30,000 as per UpToDate. When do you start second line? When the platelet count is less than 20,000 as per UpToDate. Now, if this has reached above 20,000 or there is no bleeding, then as per UpToDate, there is no treatment, you simply observe. But when it has gone down and there is bleeding, then you consider splenectomy. This is very important. You have to consider a splenectomy. Now, what does splenectomy do? It removes the major site of phagocytosis of antibody-coated platelets and the lymphocytes as well that may be responsible for producing the antiplatelet antibodies. Now, the discussion on splenectomy is very long. I will not touch on when to pursue splenectomy, when to decide it, and the timing and the pre-splenectomy considerations in terms of optimization of the pre-op platelet count or the immunization status. That's a very detailed topic. Today, my goal was to only emphasize on this clinical algorithm in respect to a therapeutic approach in a patient with ITP. So now let me go ahead. If splenectomy does not work, then you give Rituximab, okay? You do not prefer Rituximab prior. This is very important. If second-line therapy, splenectomy, does not work, then you give what? Rituximab. Okay, now if there is a contraindication to splenectomy or the patient says no to splenectomy, no, I do not want a major surgery, I do not want my spleen removed, or the patient is not eligible for splenectomy, contraindication, then you consider Rituximab. Remember, Rituximab is not given before splenectomy, it's given after splenectomy. Again, you check the platelet count. If still the patient's platelet count are decreasing or below 20,000 or the patient is bleeding, then you consider TPOA receptor agonist. Okay, now in 5B, I will talk about the complete indications and the timing of TPOA receptor agonist and the three main common types of this drug. So I will teach you the overview and the choice of the drug and what's the efficacy of these drugs. And this is very important for the step 3 and APIM exam. If you guys have any questions, just let me know. My email is clients@3mdiagnostics.org. I hope this algorithm will but I'm confident rather that it will definitely help you uplift your score. Have a nice day. Take care.